This is Nursing 517, 617, Drugs Affecting the Cardiovascular and Renal Systems, Part 2. Let's start off by talking about angina. Angina is a clinical syndrome characterized by chest and/or arm discomfort. It's caused by an imbalance between myocardial oxygen supply and demand, which is also ischemia. It's associated with coronary artery disease. The pain is reproducible with physical exertion or emotional stress. It's relieved by nitroglycerin. So what are the goals for therapy for angina? Well, treatment is aimed at lifestyle changes and surgical intervention. So we want to eliminate the anginal pain. We want to get their blood pressure to less than about 130/85, and we want their pulse to be over 70 beats per minute. We want to reduce the risk of myocardial infarction and death. So how do we manage it? Aspirin, nitrates, beta blockers, calcium channel blockers. We can use the angiotensin converting enzyme inhibitors or the ACEs, statins, and also agents that serve to increase the myocardial oxygen supply, which is nitrates, right? Nitroglycerins for short term, and isosorbide for long term, and calcium channel blockers. Calcium channel blockers cause arterial smooth muscle relaxation, which leads to peripheral vasodilation and decreased afterload. Calcium channel blockers may cause coronary vasodilation. And nitrates action is low doses of nitroglycerin that dilates the veins, decreasing the venous return to the heart. It decreases preload. Higher doses dilate arterial vessels, causing decreased vascular resistance or afterload. Some dilation of coronary arteries occur. Atherosclerotic vessels do not dilate, right? So what are the precautions? Well, it's contraindicated in hypersensitivity, and we're talking about nitroglycerin, right? It's contraindicated in hypersensitivity or idiosyncratic responses. The transdermal patches, some people may have allergy to the adhesives in those patches, and that can limit the use for them. If someone is pregnant, you want to weigh the benefits versus the risks. And beta blockers decrease the force of myocardial contractility and decrease heart rate and conduction velocity. So what do beta blockers do? Beta blockers decrease the force of myocardial contractility and decrease heart rate and conduction velocity. Beta blockers decrease systemic vascular resistance and blood pressure, afterload. So decreased myocardial oxygen demand equals decreased anginal pain, right? So decreased myocardial oxygen demand equals decreased anginal pain. So when we talk about calcium channel blockers cause arterial smooth muscle relaxation, which leads to peripheral vasodilation and decreased afterload. The ACE inhibitors, they act on renin-angiotensin aldosterone system, or the RAS. There's decreased peripheral vascular resistance, decreased afterload, indirectly reduce the secretion of aldosterone. Decreased sodium and water retention, reducing extracellular fluid volume and preload. So you know a little bit about the nitrates, what the beta blockers do, how do calcium channel blockers work. How do ACEs work? And how are these helping in angina? So what about the aspirins and the statins? So what are we going to do with the aspirins? What is the aspirin going to do? It's going to decrease platelet aggregation to prevent the cycle of vasoconstriction and platelet buildup. So right there on the screen, it decreases platelet aggregation to prevent cycle of vasoconstriction and platelet buildup. Statins are used preventively or as a preventive measure. Statins reduce in there's a reduction in low density lipoprotein cholesterol levels. So that's why we're using the statins. And that plays a significant role in decreasing the formation of that atherosclerotic plaque. All patients with angina should be on aspirin anywhere from 81 to 325 milligrams a day. If a patient can't tolerate aspirin, then they should be on something like Plavix or clopidogrel. Clopidogrel. Plavix, 75 milligrams a day. And so if they can't tolerate aspirin, they should be on Plavix at 75 milligrams a day. Nitroglycerin is used for that exertional angina. Acutely, there's a sublingual tablet that's about 0.3 to 0.4 milligrams. There's the translingual spray, and that's used for immediate symptom relief. So if someone has angina, exertional angina, they're going to use the shorter acting nitroglycerin, right? Not the long acting. They're going to need short acting so they can relieve the angina right away. Some other drugs for angina, the ACEs, they're recommended for all symptomatic patients with chronic stable angina to prevent myocardial infarction or death and to reduce symptoms. Angiotensin II receptor blockers for patients who are intolerant to ACEs. So we know everybody can't tolerate an ACE, right? So then you're going to use an ARB, the angiotensin II receptor blocker. The beta blockers are recommended as initial therapy by all the guidance for all patients. So that would be the beta blockers. Calcium channel blockers are initial drug of choice for coronary artery vasospasm associated with angina. So the long-acting nitrates, okay, so if they're going to use that, that is not for that quick pain. A long-acting, if someone has exertional angina, they're not going to run to the long-acting nitrate. They're going to go to the short-acting. The oral or transdermal patch is used for patients who are intolerant to beta blockers. So the Isordil or isosorbide dinitrate, that's given 2 to 3 times a day with a 10 to 12 hour nitrate free interval. And I talked about that nitrate free interval in one of the last lectures. So if their chest pain is usually at night, their nitrate free interval is going to be during the daytime. If their exertional angina is during the daytime, their nitrate free interval will be at night. So the timing of the nitrate-free interval should coincide with the time of the fewest episodes of angina. Now, some considerations. Older adults, women, you want to consider if it's, the cost of treatment. So in older adults, ACEs and beta blockers if the patient has congestive heart failure. Calcium channel blockers will make congestive heart failure worse. So if someone is an older geriatric patient, you want to be careful if they have congestive heart failure of giving calcium channel blockers. There is no gender-based difference in therapy. Women are usually undertreated though, so not sure. Sometimes women don't look at their symptoms the same and they're often undertreated. Nitrates are the cheapest of the medications. Beta blockers, there's about a mid-range cost for that. The new drugs, the drug reps will try to get you to use those. Do not be afraid to use those older drugs because they're cheaper and they're tried and they're true. So, calcium channel blockers and ACEs are usually the most expensive. Generics, of course, are always going to be less expensive. If you're treating someone with angina, you have to do an initial assessment. You want to make sure you get an EKG, get some fasting lipid levels, a chest x-ray, a CBC. Check them for diabetes, check their thyroid function and their renal function. So initially, if somebody comes in, hey, I hadn't really been feeling good. I went for a walk, started having a little bit of chest pain. It wasn't really bad, but it just kind of bothered me some. Are you just going to say take some aspirin and call me tomorrow? Of course not, because you're going to be the providers. So you have to take that seriously, right? I mean, you may get a young person that comes in 2025. Doesn't mean they don't have a cardiac history. If somebody tells you they have chest pain with exertion, that's a problem. So you want to get and then do an initial assessment of them, ask the questions. You guys are taking 507 or have taken 507, do your cardiac assessment, get an EKG, lipid levels, chest x-ray, complete blood count, check them for diabetes, check their thyroid, and do a renal function. And then you want to monitor them. Make them keep a journal or find out about how many episodes are you having. Ask their questions because you want to know about when you're talking about the angina episodes, the presence of them, the characteristics of them, and the timing, right? These are some things you guys know from assessment. Evaluate them about every 4 to 6 months during the first year of therapy. So you're gonna see these patients quite often. They're probably also going to be referred over to cardiology because if you have somebody that's coming in with chest pain, exertional chest pain, you don't want to be the last resource. Refer them to cardiology. There's no shame in that game. So some questions you may want to ask them was, have their level of physical activity decreased since their last visit? So if you start them on something, when they come back, how's their level of activity? Are they doing better? Is that getting worse? How well are they tolerating the therapy? And how successful have they been in modifying their risk factors and improving their knowledge about ischemic heart disease? So you want to make sure they have a very good understanding. And have they developed any new comorbid illnesses since the last time you saw them? Has the severity or treatment of the known comorbid illnesses worsened their angina? Patient education is very important. You want to make sure you're telling them to take that drug exactly as prescribed. Again, and I've said this before, if the anginal symptoms occur at night, they need to have a nitrate-free time during the day. If their anginal symptoms occur during the day, they need to have a nitrate-free time during the night. You want to teach them how to store the nitroglycerin and you want to tell them to look for the expiration date because that medication will lose potency. You also want to tell them to avoid heat and moisture around their nitroglycerin. Okay, let's talk about heart failure. Heart failure is a complex syndrome that can result from any structural or functional cardiac disorder, and it impairs the ability of the ventricles to fill or eject blood. That's cardiac output. Um, do a review of your pathophysiology of heart failure. So that's just for your own knowledge. If I'm not discussing it, and I'm not sending you to go look for it, I'm just saying you need to have a review of your pathophysiology of heart failure. This is pharmacology, so I'm not going to do a whole lecture on patho, okay? All right, so we're moving on. So this is just the different stages of heart failure. The American College of Cardiology stages it, and then the New York Heart Association also has classifications. Stage A, they have a high risk for developing heart failure. Stage B, they have structural heart disease, but they're still asymptomatic. Stage C is structural heart disease with past or current symptoms of heart failure. And then there is stage D, which is refractory heart failure. Am I going to ask you the stages of heart failure? Am I going to say, well, what is stage A on an exam? Probably not. But again, remember I told you, some of this you still need to know it. But I'm not going to ask you the stages of heart failure on an exam. Now, will I ask you about treating heart failure? Of course. So if somebody comes in with stage A, and this can be easy to correlate. Stage A, of course, A is not as bad as stage D, right? Stage A, stage B, stage D. Stage A, not so bad. They come in with stage A, do some lifestyle modifications, maybe have taken A's or an R lifestyle modification. Stage A, some more light, okay? Um, Stage A, you're going to treat dyslipidemia, you're going to treat diabetes, hypertension. If they have hypertension, probably give them diuretics or ACEs, right? ACEs are the drug of choice in patients with diabetes. An angiotensin II receptor blocker, those are considered if the patient cannot tolerate an ACE. But remember, they're more expensive. Stage B, they're going to have the ACEs, probably in all the patients if they can tolerate it, ARBs for patient who can't, and beta blockers in most. I don't have stage C, but yes, there is a stage C. ACEs and beta blockers again, diuretics, DISH, spironolactone. You don't have to have that memorized, but stage D is probably the worst. It is the worst because you might even be considering hospice care. Entresto, we talked about Entresto before. Dobutamine, and for the inotropes, you may want to give dobutamine. You probably won't be taking care of this patient in stage D unless you are working with a cardiovascular clinic. So now you might run across some stage A's. You might see them in clinic for something else, but you're not going to be first line taking care of these patients. So, what are some of the treatment considerations for heart failure? Well, of course, early therapy works best. As heart failure starts to progress, then non-selective beta blockers with both alpha and beta impact work better than cardioselective types. Entresto has dramatically decreased the risk of death and hospitalizations. So Entresto is like, remember I said it's a game changer. You want to monitor their functional capacity, their fluid status, their cardiac rhythm. You want to check weights. You want to check their weight changes. So you're going to do your assessment for that, right? You're going to look for jugular venous or JVD, jugular venous distension. And with labs, you're going to check electrolytes, creatinine, thyroid, liver functions. Make sure the patient is involved in treatment planning. You always want to have them on board. They may need to do some home monitoring. You want to educate them on the drug therapy. Definitely take the medication as directed and do not miss or double up on any doses. Okay, so let's move on to hypertension. So, primary or essential hypertension accounts for about 95% of hypertension. Atherosclerosis is secondary with about 5%. Blood pressure relies on a balance between cardiac output and peripheral vascular resistance. So with these patients, you're definitely going to be doing lab and diagnostic workups, like you're going to get an EKG, urinalysis, blood glucose. You're going to check their serum potassium and their creatinine, their calcium. You're going to also check lipid profiles on these patients, C-reactive proteins and homocysteines as well when you're doing workups on patients that have hypertension, right? So you want to make sure that if someone comes in with hypertension and you're monitoring them, which you will take care of a lot of patients with hypertension, make sure you're monitoring their labs. So classification of hypertension: normal, systolic blood pressure is less than 120, diastolic is less than 80. Early hypertension is 120 to 139, over 80 to 89. Stage 1 hypertension is 140 to 159, over 90 to 99. And stage 2 is anything that's greater than or equal to 160 or greater than or equal to 100 diastolic. So they used to have an old term called pre-hypertension. Nobody uses that anymore. Why? Well, patients really didn't appreciate the degree of risk that was associated with it. So if you told a patient you have pre-hypertension, that kind of went in one ear and went out of the other. I have pre-hypertension, nothing to worry about. I'm going to be okay. So they didn't really appreciate the risk of pre-hypertension going into hypertension. Um, so they didn't really understand the impact of their blood pressure being out of a normal range. So they have some changes in how patients are treated, especially changes in the definitions for control for older adults. We do allow for higher values for these older adults to avoid those orthostatic falls. So, older patients are already at risk for falling, so we don't want to drop their blood pressure and make them fall, give them even greater fall risk. Beta blockers are not first-line drugs for hypertension, and there's an emphasis on using multiple agents at lower doses rather than one agent at a maximum dose. So, way back in the day, we would start a patient on hydrochlorothiazide, you know, 12.5, then 25, and then it's like, okay, now it's time to add something to it. And we would add lisinopril 10 and lisinopril 20 and lisinopril 40. And so you just would start going up. Well, the goal now is, instead of having, say you just started your patient on lisinopril, you don't have to max out on lisinopril before you add another agent. So that has changed. So what are the goals of treatment for a patient with hypertension? Prevent the rise of their blood pressure with age, improve the control, so we can want to get it below 140 over 90, obtain a systolic blood pressure goal. You want to improve recognition on the importance of the risk factors. You want to reduce ethnic, socioeconomic, regional variations in hypertensive care. So we want to make sure that we're getting out there and educating everybody on the importance of being treated for hypertension. So that is why you see it at health fairs, churches, clinics, wherever we want to get the word out. So there are definitely benefits of lowering blood pressure in stage 1 hypertension, because it decreases their cardiovascular risk, right? So achieving even a 12 milligram reduction in their static systolic blood pressure over 10 years will prevent one death. So, and if you can prevent one, that's a lot. So getting them treated, reducing their blood pressure improves their cardiovascular risk factors. So we talk about rational drug selection, which you guys learned about way back in the first lecture. Always start with lifestyle modifications first. Most patients need to maybe lose some weight. We talk about the dietary approaches to stop hypertension, which that is the DASH diet. If you did not know, it is the dietary approaches to stop hypertension. Dietary sodium restriction, because most patients consume too much. It's not a restriction, but a reduction. So, they need to make a conscious effort to reduce the amount of sodium they're consuming. Definitely limit alcohol consumption. And you want to tell them they need to be physically active. So when you're teaching your patient about hypertension and lifestyle modifications, weight loss, DASH diet, reduce their sodium dietary intake, limit alcohol consumption, and get moving, get moving. So what is the step therapy for hypertension? So set an appropriate minimum therapeutic blood pressure goal. It used to be less than 120/80, but that's not the case anymore. Be patient and work on attaining the blood pressure goal over many weeks to months. So way back a long time ago, when I started practicing, we tried to get their blood pressure down. They came in, their blood pressure was up. It was bam, bam, bam. We were just trying to get their blood pressure to come down quickly. Well, that is not the goal. And the patient is going to feel miserable. So you have more time so you can do it over several weeks to months. That patient has probably been walking around with that blood pressure for months and months and months and months. So now you're going to slowly bring that blood pressure down so that patient can tolerate being on the medication. You're going to titrate their blood pressure medications no more than about every 4 to 6 weeks. So you're not going to bring them back in 2 weeks and do an increase, in another 2 weeks and do an increase. No, every 4 to 6 weeks you can do an increase. Don't automatically assign to the drug symptoms reported by the patient. So you want to take care of a patient, but don't automatically go by assigning a drug based on their symptoms. Plan to use more than one drug. Remember, I told you we're not maxing out a drug and then starting another one. So already start thinking, you're probably going to have this person on more than one medication. Treat to achieve a goal of their status blood pressure in older adults. Remember, they have a little bit more leeway. And if they have any extracellular fluid volume, you definitely have to control that. So in the older adults, treat to achieve their goal status blood pressure in older adults, even if the diastolic blood pressure is normal, but go more slowly. So allowing their systolic blood pressure of 150 to 160 if they're asymptomatic. Initial drug therapy would be angiotensin converting enzyme inhibitors, or ACEs, or calcium channel blockers. But remember, the ACEs are a little bit cheaper than the calcium channel blockers. If their blood pressure is more than 20 millimeters of hemoglobin above the systolic goal, or 10 millimeters of hemoglobin mercury above the diastolic goal, then you can start with a mild diuretic and add on quickly to achieve goals. So way, way, way back, many moons ago, anybody who was brand new with a diagnosis of hypertension, we started them off on hydrochlorothiazide. So one thing you want to think about when giving somebody hydrochlorothiazide, especially a young person, is their working environment. Because hydrochlorothiazide is a diuretic, right? So if you have a young male and he works offshore and he does most of his work outside, and you give him a diuretic and he's not hydrated, what do you think is going to happen to that young male? So we have to think about the medications that we're prescribing, which is why you have to know side effects, adverse drug reactions. You have to know cost because you're treating the whole patient. Okay, some indications for individual drugs. For heart failure, diuretics, beta blockers, ACEs, ARBs, aldosterone antagonists. If they have had a heart attack, then you're going to consider beta blockers, ACEs, and aldosterone antagonists. If they are a high coronary disease risk, then beta blockers, diuretics, ACEs, and calcium channel blockers. If they have diabetes, diuretics, ACEs, ARBs, calcium channel blockers, like a lot of these, right? Seems like you're giving them almost the same medication. So these are the medications of choice. Somebody with chronic kidney disease, of course, ACEs, definitely ACEs. You can use ARBs until stage 3 of chronic kidney disease. For recurrent stroke prevention, we want to go with diuretics and ACEs. So don't wait until full dose of the first drug. Remember, so we're stepping up to multiple drugs now. So we're not going to max out that first drug before we start another one. Add a second drug or substitute a drug in a different class if your medication is not effective for symptoms. Choose the second drug based on it being different from the adverse drug reaction profile and action of the first drug. So you're not going to take two drugs in the same class, is simply what that's saying. If one drug class, you start on that, your second drug is going to be a different drug class. With children and adolescents, the definition of hypertension for them is based on age, height, and blood pressure. Lifestyle modification is always your initial therapy when the parameters allow for it. So I say always, but if you have somebody who's come back for serial blood pressures and they have 160 over 100, well, you're still going to tell them lifestyle modifications. That is still initial therapy, but you're also going to start a medication. But lifestyle modification is initial because everybody has to have lifestyle modifications. And drugs are similar for those older adults. Hypertension occurs in 2 out of 3 adults older than 65 years old. That's a lot. Again, begin with lifestyle modifications. Target blood pressure goals are less stringent in young adults. With women, oral contraceptives and hormone replacement may increase blood pressure because of weight gain. So you have to be careful with women who are on oral contraceptives or hormone replacement. During pregnancy, there may be increased risk to the mother and the fetus. So, methyl-dopa, beta blockers, and vasodilators are the drug of choice for pregnant females. Avoid ACEs, ARBs, and direct renin inhibitors in pregnant females. So, methyl-dopa, beta blockers, vasodilators, drugs of choice. Avoid ACEs, ARBs, and direct renin inhibitors in pregnant females. Preeclampsia occurs after the 20th week of gestation and it requires intensive monitoring. Pre-existing hypertension is not the same thing as preeclampsia, so know the difference. Native Americans have about the same or slightly highly prevalent rate with blood pressure compared to the Caucasian population, and Hispanics have the same to slightly lower prevalence rates. African Americans have higher and earlier hypertension incidence, which we know that, right? They may have a reduced response to monotherapy as well. They may have a reduced response to ACEs, ARBs, and beta blockers, but that response is equal if you mix it with a diuretic. Bidil was the first drug suggested for African American patients specifically. And calcium channel blockers is the first line for most African Americans. Most African American patients, not all, but most can't tolerate ACEs. So you're going to have to monitor your hypertensive patient, right? You're going to check their blood pressure, lab values, EKG. I said this at the beginning. You're going to do blood pressure measurements of them, tell them they need to avoid caffeine. If they're coming in for a blood pressure measurement, you want to tell them to avoid caffeine, smoking within 30 minutes of the visit, and exercise. You're going to check their lab values. You're going to be monitoring if there's any adverse drug reactions. You'll be checking their electrolytes, their renal function, CBC, EKG. So self-care monitoring, that's important because somebody may come in and say, hey, my blood pressure is always good at home. But when I come into the clinic, it goes up. Well, they may have white coat syndrome. Okay, and we are almost done with this one. Let's see. That is it for this lecture. If you have any questions, please let me know.